Good afternoon, viewers. Good afternoon, everyone, the faculty and members of the patient support group. Hello and welcome to webinar series 5 of Indian Society of Bone Marrow Transplant Patient Support Group. I am Dr. Venkatesh Igbote. I'm a director at Clinical Hematology and Bone Marrow Transplant Services in Aurangabad, Kamal Nayan Bajaj Hospital, and I welcome you to today's webinar on acute graft versus host disease. Today, we have with us the entire panel of Indian Society of Bone Marrow Transplantation. Presently, this initiative by Indian Society of Bone Marrow Transplantation is to engage and enable patients in their fight against blood diseases through the curative method of bone marrow transplantation. Here we engage and interact with all patients about various issues surrounding bone marrow transplantation. It is my pleasure to welcome the new president, Dr. Shashikant Apte, the director of hematology, Department of Hematology at Sahyadri Hospital, and now the current president of Indian Society of Bone Marrow Transplantation. I also would like to welcome the mentors of Indian Society of Bone Marrow Transplantation who have led from the front in order to organize this initiative. Dr. Tapan Saikia, head of the department at Jaslok Hospital and Research Center, Mumbai, and Dr. Revati Raj, head of services of pediatric bone marrow transplantation and a pioneer in Apollo Hospital, Chennai. I'm also joined by esteemed members, Dr. Silki Jain, who is senior pediatric hemato-oncologist at the Postgraduate Institute of Child Health Hospital, Noida. Ms. Riya Daruwala, who is a consultant psycho-oncologist from Narayana Health, Bangalore. Next slide. Today, we welcome our esteemed speaker, Dr. Ranjit Kumar Sahu, who will speak to all of you about acute graft versus host disease, a very challenging topic, a very challenging time for all patients. He is additional professor, Department of Medical Oncology, All India Institute of Medical Sciences, New Delhi. I invite him to start his talk. Welcome, Dr. Ranjit Sahu.
Hi, Dr. Venkatesh.
Yes, hi.
Hey, good afternoon. So, actually, I am trying to log in from my other device.
Fair enough.
There is an issue. I have talked to Miss Arundhati. She is resolving it. So, I will take a minute.
Of course, of course. For the viewers who have joined us for the first time, we will be listening to Dr. Ranjit Kumar Sahu talk about acute graft versus host disease for the next 20 minutes. This will be followed by a panel discussion where we will be answering questions raised by patients. We will be inviting our moderator, Mr. Neeraj Trivedi, to moderate the session. We have esteemed panelists from all fields like bone marrow transplantation services, clinical pathology who help diagnose and stage the diseases. Then we also have psycho-oncology specialists who will talk to you about how we should deal with this challenging time. And subsequently, if there is enough time, we will take one or two questions from the audience as well.
Could we do the slides and Dr. Ranjit could talk, Arundhati?
If you could share the slides, Arundhati, that will help start the session.
So let me call sir then to share the slides so that we can share from our side.
Oh, okay. He has not put up the slides.
No, sir.
Or at least if you can ask him to share his slides to you, then you can put it up if he's having a trouble logging in. That way he'll
Yes,
be
sir.
able
Yes, sir.
to
I
reflect
will ask him. Yeah.
quickly. Thank you.
Please.
As they are trying to load the slides, Venkatesh, maybe I think we can talk about the couple of patients that have really touched our lives. You know, when we see acute graft versus host disease, I think that's something that really makes us think about what could we do better for our transplant patients. So
Yes, ma'am.
I
Please go
think a
ahead.
lot of things
Would be great if you could start.
Ranjit's talk and the panel discussion will cover. But I think
Yes.
for the patients that are here, graft versus host disease is something that we talk about when we are counseling them during the transplant, but when it actually does happen, it uh, really brings people down, because it's not just the suffering to do with the skin and the gut and the liver problems, but also the infection risk. So I think in this field, the one message that people should take up is that there are lots of advances happening to prevent GvHD and to treat GvHD without as much side effects as we saw when we started transplants 25 years ago. So things are looking better now because we have better methods to prevent, we have better methods to treat. I think the people who did have the GvHD can share that it was a tough time, but
Yes.
things are getting better is what we tell our patients these days. Are we ready with Dr. Ranjit's slides, please, Arundhati?
Ma'am, he is sharing.
Okay.
We're really sorry for this technical delay.
Yes, and like Dr. Revatiraj said, it is a challenging time. Patients who have undergone therapy for GvHD will also know that there is an upheaval in terms of the way their body and mind go through, uh, and none of it can really be touched upon directly in the counseling. So it is an ongoing process when we speak about graft versus host disease, and that is the reason why we have kept this session as a completely separate session. Um, uh, in fact, the good part about it is the last decade has seen great advances, primarily through our understanding of how graft versus host disease happens, to whom it happens, and how one should address it. Because more and more knowledge has happened along the immunology part of it, that has helped us to treat our patients and to prevent graft versus host disease better. Um, Particularly in patients who have diseases which are non-malignant in origin. And that is a great aspect of present day treatment of graft versus host disease. So, Dr. Ranjit Sahu, over to you.
Give us a minute, sir. He is just joining in the Zoom right now. Yes.
Fine, fine.
We're ready with the slides.
Yes.
Hello, everyone. Good afternoon. Are my slides moving? can you move the slide ahead, please?
Nirav, please move the slides. Yes.
Yes. So thank you for this kind invitation to interact with all of you. And this is a very important aspect in all physicians. I mean, to deal with the toxicities. And can we move to the next slide, please? Next. So, graft versus host disease, it is a common complication, for the patients who undergo bone marrow transplantation. Now, bone marrow transplantation could be of at least two types. It could be an autologous bone marrow transplantation, or it could be an allogenic bone marrow transplantation. The allogenic bone marrow transplantation is the process when you are selecting a healthy donor. You are extracting the stem cells from the donor and you are infusing it to the patient after giving him certain chemotherapy or without radiotherapy. Now, this terminology, it means there is something called as the graft. The graft is the stem cells that are obtained from a healthy donor, and the host means the patient himself, the patient who is undergoing the bone marrow transplantation. And this is not a complication in patients who were transplanted their own stem cells, as we see in certain conditions like multiple myeloma, where we take the stem cells from the patient and we infuse the stem cell back to the patient. Next slide, please. So, why we should discuss about graft versus host disease? As we could see it, I mean, these are the causes of death of patients following bone marrow transplantation at least beyond 100 days. And you could see the graft versus host disease beyond 100 days, even when they are happening at a later time point, close to 13% in mass sibling and close to 10% in unrelated donor setting could be having complications leading to mortality. So understanding graft versus host disease, so it is not just an early complication which would result in death. Even at later time points, it might result in mortality, which is clinically significant. Next slide, please. So next. So now there is an immune discrepancy here. The patients are normally having immunodeficiency, especially patients who have got malignancies like leukemia, and there is a treatment multiple times with chemotherapies that are the cytotoxics that would further immunodeplete them. Again, before the stem cells are been transfused to these patients receive very high doses of chemotherapy or radiotherapy. It will further deplete the immune system. While when we take out the stem cells from the donor, stem cells or the graft from the donor, these cells are immunocompetent. So when the graft is infused to the patient, these immunocompetent cells that are the lymphocytes, they will try and attack the patient's normal healthy cells in addition to the leukemia cells. It all would kill both the leukemic cells that are malignant as well as the normal healthy cells. Next, please. So the donor cells that trigger this reaction are the lymphocytes, which are a part of, which are basically the white blood cells. They're called as the T cells. They are the most important part of the immune system, and they help to protect the body against infection and fight cancer, especially in health, in normally. But during this BMT or this post BMT setting, they would try to cause this complication. Next. So most of the cases of GvHD as of today, in the present day, they are mostly mild or moderate, and they resolve with time. However, in close to 15 to 20% of the cases, the graft versus host disease could also be very severe, and in some cases, it could be life-threatening. Next. So, which would be resulting in the mortality. So, patients who develop GvHD, they would usually develop in the first 6 or 9 months or a year. However, GvHD can also occur beyond a year. Next. So GvHD is at least of two types. To the duration, this is a classical definition. We take 100 days or 3 months. And if the GvHD is happening, if the reactions are happening within the first 100 days, they are called as acute GvHD. When these complications are happening beyond 100 days, they are called as chronic GvHD. Now, these are not very strict definitions. We can find acute GvHD beyond 100 days, especially when we are tapering the immunosuppression. Especially in patients who have leukemia, we need to taper immunosuppression after a certain time. And if the patient is in a good remission or the disease is well controlled, we can delay it for some time. Uh, at times, when we take patients with a lot of disease before BMT, then we have to taper the immunosuppression a little early. So when we start to taper immunosuppression, let's say from day 90, and we slowly decrease it 25% every week or 2 weeks, at times these reactions, they may tend to happen. In some patients, we even after BMT, we have to do another cell infusion. This is called as donor lymphocyte infusions, because they are immunocompetent lymphocytes. They will try to kill the leukemia cells better. So when we give DLI, and all the DLIs we most commonly administer after 3 months, so they may cause reactions. And these reactions, even though they are happening after 100 days, they tend to mimic um, the conditions which happen within 100 days. Now, in the first 100 days, what happens is, that is because of the chemotherapy or the radiotherapy which is given before the stem cell graft, there is a lot of cytokine storm. So the GvHD which is happening within the first 100 days, they tend to be severe, and the risk of death is significant in such cases. While when they happen after 100 days, the risk of death and the manifestations, they could be different than what happens in the first 100 days. Next, please. And there are, because we now do a lot of different type of BMTs, so in some 10 or 15% cases, there are patients where we can find the evidence of both acute and chronic GvHD, and we call it as overlap syndrome. These are difficult to manage. Next. So this is the tabular form. I took it from clinical care options. So normally the classic acute GvHD is the one which happens in the less than 100 days. And there is something called as the late onset acute GvHD that happens in more than 100 days. There is other definitions like persistent. The acute GvHD has happened within, let's say, 90 days, and it is taking time to get controlled. So they are also labeled as acute GvHD. In these patients, there is no evidence of chronic GvHD. There should be no evidence of any chronic GvHD organ sites. Now, the classic chronic GvHD, it technically doesn't have any time limit as of today. And the manifestations are very classical. They manifest in most commonly in the oral mucosa or the eye, or at the later time points in liver. And there is no evidence of acute GvHD. So they are called as classic chronic GvHD. And overlap syndrome as well. Now there is no time limit. And there is presence of both acute GvHD as well as chronic GvHD. Next slide, please. So who are the patients that are at risk of developing graft versus host disease? Now, the most important is the age. If it is a pediatric patient, then the risk of GvHD is very low. But if it is an adult patient, those who are 40 years or more, the risk of GvHD is considerable. Second is HLA matching. Now, HLA is human leukocyte antigen, and this is a gene. And if it is determinant of the immune function of the T cells. So this gene should be matched between the patient as well as the donor. So if it is a completely matched situation like 10 by 10 or 12 by 12 fully matched sibling, then it is, I mean, the risk of GvHD is going to be very low. But if it is anything worse than that, like let's say 8 by 10, 6 by 10, they are called as haploidentical family donors. There the risk, it considerably increases. The same, I mean, even if it is HLA matched, if it is not a sibling and we are getting something called as matched unrelated donor, I mean, the donor is somewhere else, not from the family, then also the risk of GvHD might increase a bit. The third point is the type of graft that we
I think there is a problem with the reception. Is there a problem with the connection?
Yes, we lost Ranjit sir, I think, in net.
Yeah, I think we lost Dr. Ranjit somewhere. Just call him. That way it will be. Dr. Ranjit, can you hear us? I think there's a connection issue.
Arundhati?
Yes, Nirav?
Ranjit sir, like having a net issue, I think.
I think the video is stopped working.
Disconnected.
Yeah, if you can just reconnect, no problem. So there will always be some technical errors. Sorry about that. So as we have already listened to.
Sir has joined again. Sir
Yeah.
has joined.
Yes.
uh,
Yes,
I am sorry for the inconvenience.
no
So
problem.
I'll start. The graft also plays an important role here. If the graft is derived from the bone marrow, then that is a better graft. The risk of GvHD, especially the chronic GvHD part, it is going to be lesser when you are giving the graft as bone marrow. When you are giving a peripheral blood graft, which is now very commonly used, especially in settings where like blood cancers like leukemia, then the risk of GvHD, it is more, especially the chronic GvHD. Next, please. So, how do we prevent GvHD? Because GvHD is a function of T cells. It is of aberrant T cell function. So, if we inhibit this T cell lymphocytes, then the risk of GvHD it lessened. Now, the most important drug which can achieve that are called as cycloneurin inhibitors like cyclosporin or tacrolimus. They are the most important drugs which has revolutionized all the transplants, be it bone marrow transplant or organ transplants. This was followed by a drug something like methotrexate or mycophenolate mofetil or MMF. Also, there are antibodies which can bind to T cells like anti-thymocyte globulin. They are very, very efficient in decreasing the risk of GvHD. There is another drug called as abatacept, which also, I mean, it doesn't decrease the T cell numbers, but it inhibits the T cell function so that there is no T cell overreactions. Next, please. And now this is also a very important drug. I mean, cyclophosphamide is a cytotoxic. When it is used as a very high dose, like 50 milligram per kg for 2 days, that is 100 milligram per kg. And this is given after the stem cell graft is given on day 3 or with or without day 4. Then it kills all the T cell lymphocytes, and the risk of GvHD decreases considerably. And this is the most important drug as of today, especially in the setting of haploidentical BMT. Next. And there are others like there are also evidence that when we use low doses of steroids, and now recently there is another drug like ruxolitinib, when it is used as a preventive measure, then the risk of GvHD it declines considerably. So as of today, I mean, GvHD can be prevented in the most, but still in close to 40 to 50% of the patient, it could still be an issue. Next. So the T cell, we normally give drug to deplete it. Now there are depletion techniques where you deplete the T cells from the stem cell graft. And after depleting that, the GvHD risk, it reduces considerably, but at the same time, the risk of infection, because these T cells, they are also fighting the infection, the risk of infections also increases. Next. So when the GvHD manifests in the first 100 days, the median time is in the first month itself, and the target organs are the organs which functions very rapidly. The three most important organs in our body is our skin, then our gut, that are the bowels, both small bowel and large bowel, and the liver. This is a representative figure where it was shown that the stem cells that we have pushed in, the T lymphocytes have started reacting, and you could see there is a rash in the thigh. Next. And now because of, the most common organs to be involved in acute GvHD, skin, followed by the gut. This is the colonoscopic picture. As you could see, the mucosa of, this is the large bowel picture. The mucosa, it looks very, very angry here. And when a biopsy is obtained, you could see the black cells are the cells which have undergone apoptosis. These cells are completely destroyed. Next. So how do we treat the graft versus host disease? There is no rocket science here. We just try to inhibit the T cell lymphocytes. The most important drug which is used to inhibit the T cell lymphocyte are the steroids, which is given at a high dose, let's say 1 milligram or 2 milligram per kg, depending on the situation. And if these patients are not responding to steroids, then the other drug, it is called as ruxolitinib. This inhibits the JAK-STAT function. It is a JAK inhibitor. They are also effective in close to 50% of the cases. These two things are most commonly used and approved. Now there are other drugs like etanercept, which inhibits TNF alpha. At times, ATG can also be used. There is another method called as extracorporeal photopheresis, where you do apheresis. This is something like taking your WBCs out of your circulation. Then we mix them with a drug called as sorolin and expose them to ultraviolet light, and then they are reinfused to the patient. By doing these maneuvers, these T cells, they undergo apoptosis to an extent and causes further inhibition. Next. So, and this is something very new. It is called as fecal microbiota transplant, the stool transplant. This is also coming up in a nicer way. There is still more evidence requires to be accumulated, and this also helps because the GvHD process is destroys our gut microbiome. If you could reconstitute the gut microbiome by giving the FMT, then the GvHD, it declines considerably. Next. So another cellular therapy is called as, these are called as mesenchymal stem cells. Now mesenchymal stem cells are approved for treatment only in few countries. It is still not approved in our country to be used in acute GvHD. There could be some off-label use in some desperate situations. They are also very, very important in immunomodulating the T cells so that the GvHD is controlled. Next. So to conclude my presentation, GvHD, it's remain a very important side effect of allogenic BMT. This is associated with risk for life. GvHD is best prevented, and the treatment is effective. And there are a lot of new drugs and approaches which are there, and they are promising, and they will happen in future. And maybe 10 years down the line, the GvHD, the incidence of GvHD, I wish, I touch wood, it would become zero. Now that is my last word. I will conclude my presentation here.
Thank you very much, Dr. Ranjit Sahu, for taking us through the entire journey of graft versus host disease in the acute setting. I'm sure we will also have another session which will address chronic graft versus host disease because it is a topic unto itself. Thank you for emphasizing what we are trying to achieve by treating and what we are trying to achieve by preventing. And to take this discussion forward, I would now invite Mr. Neeraj Trivedi, founder, director, BMT Support Foundation, Pune, to be the moderator of a panel discussion, which will include Dr. Ranjit Sahu, who we just heard, additional professor, All India Institute of Medical Sciences, New Delhi. We are also joined by esteemed panelist, Dr. Ritu Jain, who is Director of BMT and Academics, Department of Medical Oncology, Jaslok Hospital and Research Center, Mumbai. We also have Dr. Archana Lakshmanan, Senior Consultant, Department of Pathology, Apollo Cancer Center, Chennai, as our lead pathologist answering questions. We have Ms. Lakshmi R. Verma, who is a counselor, psycho-oncology, Narayana Health, Bangalore, to answer questions about mental health issues related to this new reality of graft versus host disease that the patient faces. I now invite Mr. Neeraj Trivedi to take over the moderation for this upcoming panel discussion.
Absolutely. And welcome everybody. And really thank you so much, Dr. Ranjit, I think, for a very detailed presentation on graft versus host. Yeah, I think to hear from the experts give a really different feel to the patients and a lot of confidence for all the new patients who are especially going through, bone marrow transplants. So obviously, your presentation covers a lot of things. But as a part of our support group, what we've done is we've collated certain questions from different patients across various forums and the patients who are going through GvHD. So, these are real life questions that have come up, and, I'm just going to put it up. And I think we will really take it through with the panel. So, let me share the presentation. Just give me a minute. Is the presentation visible to everybody?
Yes, sir. Just put it full screen, sir.
Yeah.
Yes.
Okay. Let's go. So I welcome all of you, Dr. Ranjit Sahu, Dr. Ritu Jain, Dr. Archana, and Ms. Lakshmi. Really, thank you so much for taking out the time from your busy schedules to help patients understand more about GvHD and kind of help resolve a lot of issues, I think, post this presentation. So thank you so much once again. And moving on with the questions now. This question, I would like to put it up for Dr. Ranjit is can we, completely prevent GvHD? If so, what measures can we take to do so?
So, thank you for that question. This is a very important question. As of today, I mean, in certain situations, GvHD can be completely prevented.
Mm-hmm.
Now, we have to, the thing is, I mean, graft versus host disease is not always bad. Graft versus host disease means there is also graft versus leukemia. So it is not just about preventing GvHD. We have to find out a balance between the graft versus host disease and graft versus leukemia effect. So when you are after GvHD quite a bit, you are also compromising the graft versus leukemia effect. It means these patients will be at a chance of having a relapse. So it is somewhat, we should say, it is a necessary evil. But yes, it can be completely prevented to an extent of 60 to 70% if we use a lot of drugs for prevention. So as of today, let's say we have a donor which is completely matched and is sibling, then the chances of GvHD in these cases will be somewhere around 30 to 40%. Now, if you are using a drug called as antithymocyte globulin, ATG, then the GvHD can be curtailed to an extent of 10% of acute GvHD, which is moderate to severe. And the risk of chronic GvHD is also declined to an extent of just 20%. So let's say the GvHD is prevented to an extent of 80% in such cases when you push heavily on the immunosuppression.
Got it, got it, got it. So thank you so much. And I think a few other questions that I had laid out, I think you've already covered it during your presentation so beautifully. Like bringing out the difference between acute and chronic GHD, overlap syndrome. And I think you just answered the question between is GvHD beneficial? Of course, if you have GvHD, you know that there is also the GVL in terms of, graft versus leukemia effect. So I think just moving on, to more towards pathology in terms of Dr. Archana, these questions, how can we diagnose GvHD? Because, like in a very real life, I'll give you my personal example. The doctors take about 2 to 3 days to find out what's really happening. So how can we diagnose GvHD, and are there lab reports or biopsy or symptoms that we need to so are there protocols laid down, and how do we do that? Can you?
Yeah. Thank you so much, sir. So there is actually no single magic test to find out GvHD. So basically, we take, like, for everything, the clinical symptoms, we start with that. That gives us a clue about which organ is involved. As we all know, if gut, then produces diarrhea, skin rash, and all those. So we begin from there. So it gives us a suspicion. Then you kind of do certain lab tests. Like, for example, you can look for serum viral levels or toxins that is being produced by bacteria, and such kind of tests. You try to narrow down your differentials. You kind of exclude the infectious etiologies. You can do such tests in blood and stool examination. You look for parasites and pathogens, which can also cause such similar symptoms. Then, after ruling out all that, there is still a very high suspicion, and it's still not very clear. So that is when the biopsy is being done, mainly being the rectum. So the advantage of the biopsy is, again, it's not magic. Like, there is no specific histological feature to tell that it's GvHD. There are clues to tell us, but basically I need to exclude, is it drug induced changes, is it infections, am I looking at a viral etiology, and all those. So the advantage is, like, I could directly see what is happening. So basically what happens in GvHD is there is a direct hit on the epithelium. So the epithelium dies. So there's something called apoptosis. That is the earliest sign that we see. See, not only am I able to identify that there is a direct tissue damage, but I'm also able to give you a grade. I'll be able to give you the severity of the GvHD. So the biopsy helps us in identifying and excluding other infectious etiologies. See, sometimes we do, like, serum CMV levels can be normal, whereas a tissue can show you a CMV. So even if there is tissue damage, if I see a CMV, I'm going to call it as a CMV associated colitis and not as a GvHD. So, you can treat CMV, and then, so in the absence of all infectious etiologies and with pertinent histopathological findings, then we will be able to call it as a graft versus host disease, and then we'll be able to grade it as well, sir.
Okay. And the same test will also bring out this differentiation of infection versus anything else that is going on.
Yeah. So actually, the infection is one thing. Is there is a regular stain that we do called hematoxylin and eosin, which is a basic stain. So based on that, just on morphology, we'll be able to identify. And then there are these special stains which we can do to identify. Like, for example, gram stain we can do to identify gram-positive bacteria, gram-negative bacteria. And these days there are immunostains. There's a special test called immunohistochemistry, which has come up for especially the viral. Like, there are IHC against cytomegalovirus, IHC against adenovirus. So if in doubt, we can do those IHCs on the tissue biopsy itself to identify those infections.
Okay, excellent. And yeah, and just thank you for reminding about the CMV related colitis.
Yeah.
It's actually very something that I went through, and I can completely relate to, what you're kind of sharing just now. So
yes.
I think moving on, yeah. So Dr. Ritu, this question, I think we would kind of put it up to you. Are there different stages of GvHD, and does the treatment vary with, with these differences? If you can elaborate, like, say, within the acute GvHD, if there is a risk stratification that you would do, and if the treatment would vary accordingly. So.
Yeah. Good evening, everybody, and I'm audible.
Yeah.
Yeah.
Yes,
Yeah.
sir.
Thank you, Mr. Niran, Dr. Venkatesh and Dr. Revati for this invitation. So I hope I can speak in Hindi, English, Marathi. So English is also fine, but because it's in the patient support group. So I'll continue in English then.
Sure, ma'am. Please.
Yeah. So your question is are there any stages of GvHD and does the treatment differ with stages? Yes. So as Dr. Ranjit mentioned, the type of GvHD, acute and chronic. So similarly, we can stage the acute GvHD or the chronic GvHD, and we can grade them. We grade also because depending on the grade, then we will treat the patient. So if it's in the acute stage, it's only grade 1, like especially suppose in the acute GvHD, we see common involvement of skin, liver, and gut. So in that, we grade them. Suppose if it's a grade 1 skin GvHD, which means that less than 25% of the skin is involved, or then we grade as grade 2, where 25 to 50% skin is involved. And grade 3 is a more severe form where more than 75% of your skin is involved. And grade 4 would be like, how burns patients, they have blisters. So it will be a very severe form of GvHD. We call it a grade 4. Then coming to the gut, suppose patients has diarrhea. So then again, we will grade them depending upon the volume of the diarrhea. If there is a blood in the diarrhea, again we have grade 4. Like depending on the quantity of the stools per day, we measure. Sometimes patients have 1 liters, 2 liters, 3 liters of absolutely watery stools. And in the more severe form in grade 3, grade 4, they'll have blood in the stools, absolute blood, water, blood. Sometimes they are just pouring out blood with spasm and pain in the abdomen. And in the similar way, we grade the liver GvHD also. So this is the way we grade the acute GvHD. And similar way, we will grade the chronic also as limited, with a limited involvement of the organs or extensive. Coming to the second part of the question, because chronic GvHD grading and staging are quite extensive, and we use a lot of scoring methods also to score like which organs are involved. In chronic GvHD, there is more organ involvement, like skin, coming from the skin, eye GvHD, oral GvHD, lung GvHD. Then we have the liver GvHD, chronic gut GvHD. Then we have musculoskeletal GvHD, vaginal dryness. So these are all like chronic forms of GvHD at different levels and different grades. Now coming to the treatment part, so definitely it's difficult to summarize stages and grading of GvHD as well, but I'm just trying to give an overall picture in a simplified version. And the treatment differs with stages, yes, definitely. Suppose if it's an early stage skin GvHD, less than 25%, we may use only local steroids. But if it is a grade 3, grade 4, then we will give systemic steroids. That is the first line of therapy, as Dr. Ranjit also mentioned in his talk. So depending, definitely, if it's a limited stage or only early stage, we may use with topical steroids. Like if we have ocular GvHD, then we may give topical steroids, we give tacrolimus ointment, or sometimes even cyclosporin drops we are using if it's oral GvHD also. But if it is an extensive GvHD or organ-specific GvHD, our treatment would definitely be more aggressive. We may take help of 1 or 2 drugs with steroids. Sometimes we may add ruxolitinib also. Some centers use etanercept also. So definitely the treatment differs. Then coming to the second part of your question, are there any foods or even drugs which can trigger GvHD, and what I should avoid taking for the first 100 days? Okay.
Yeah, and
So yes,
this is a common question. I just wanted to reiterate here is that
huh.
food is one thing that, most patients are worried about in terms of acute GvHD, especially when you have diarrhea or when you have loose motions, cramps, other things. So are there certain things that we can avoid? And does anything trigger GvHD? I think, that's where the basic question is. So as a caregiver, we fear sometimes, am I doing something wrong that will do something wrong to the patient? If any food given, it will affect the patient and stuff like that. So, that's where the question is from, I think, from one of the caregivers.
Okay. Yeah, food, and especially for our patients, most of the time the discussion is around food only. So yes, we always insist on avoiding raw food. We prefer a fresh, warm, cooked meal and maintain the good food hygiene while the food is in prepared or served. If the patient has diarrhea, we avoid milk-based products, especially if they're having diarrhea. And many a times, as we discussed, if they have severe GvHD, then at times we give them on parenteral nutrition or enteral nutrition. Sometimes, and especially in pediatric population, they will get a enteral feed, or we will put a rice tube also and feed them. And in chronic GvHD, your question is in the first 30 days. Okay, so in acute,
Yes.
so in the acute, suppose in acute 100 days, then we would avoid them. They have oral GvHD or gut GvHD, to avoid spicy food. Milk-based products should be avoided, and fresh food, hygienically prepared food, and food of their choice. In my practice, I always tell the patient that you should eat what you want, not the family wants you to eat. So, we do enough to make the appetite go down. There is a loss of taste, loss of appetite, and then we Indians will just insist that no, you have to eat this and that. So I tell the patient that food of your choice, so that sometimes seeing the food also, the way food is being presented, they feel like eating. So these are the precautions we ask patients and the attendant to follow when they are having acute GvHD. So
Fantastic.
spicy food.
Yeah, and just
Well,
one differential that we would want to add is, veg and non-veg again is a very common question. If you may just want to take 30 seconds to cover that.
Yes. So actually, I don't recommend that you avoid veg or non-veg food. I leave it to the patient's choice, patient's preference. But for me, the food has to be cooked food, hygienically prepared at home. Avoid eating very spicy food and the food of your choice. And when patients, again, I also insist on having a lot of curds in the diet, as a probiotic.
Oh, fantastic. Thank you so much. I think, so now we move to more open-ended questions. And I think, Dr. Ranjit, if you want to take this question, what is the first line of treatment for GvHD? And when is the earliest response that we can normally expect?
So the first line treatment of acute GvHD, or be it chronic as well, it is steroids. And if it is a low or moderate type of acute GvHD, we start with steroids. Now there is a type of GvHD, if it is only grade 1, then these patients, they actually do not require any sort of treatment. If it is somewhat more than grade 1, they might require some treatment. So if it is more than grade 1, that is, let's say, intermediate risk GvHD, then they would require steroid at 1 milligram per kilogram. Let's say if the patient is a 50 kg patient, then he would require something like a 50 milligram of a drug called as methylprednisolone, either oral or IV. IV is preferred. So that is the way. And the responses could be dramatic. If it is an easy grade GvHD, some 70 to 80% responses would happen in the first week itself. If it is a severe GvHD, then close to 40 to 50% of responses will happen to steroids. Now, in a clinical practice, by definition, everything should be checked by day 5. But if you look into the clinical situation, let's say if it is a low risk type of GvHD, the patient is not very sick, the patient is okay, then you can actually prolong the responses. I mean, to take a call whether you have to change the drug or add a drug, you can wait for at least a week. But if it is severe GvHD, at times you have to take a decision by the 3rd day. If the patient is not responding to an adequate dosage of steroids by 3rd day, then you have to think of a second line in a clinical situation. Otherwise, 5th day is considered as the sort of a benchmark At fifth day, if the patient is not responding or progressing, you need to think of other line of treatment.
Okay. Okay. So what other line of treatment in case of the second line therapy? What would that be?
Yes. So when you look at the second line options, there are both approved and off-label options. The approved option is, it is called as a drug as ruxolitinib. It is manufactured by Novartis only as of today. It is called as Jakavi. That is the drug which is used as second line. And the only issue with that drug is it is an effective drug, but the issue is the cost. It could be a little costlier. The other option, which is also frequently used across the country, is a drug called as etanercept. So it is a TNF alpha blocker. So it is also costly, but it is not as costly as ruxolitinib. In our clinical experience, what we have found is ruxolitinib, it looks a little better than what etanercept was previously doing. Or it could be an improvement in supportive care as well. It is very difficult to say, but it is very difficult to make out which one is a better drug because there is no such literature available. But ruxolitinib is possibly a little more preferred than the other drug like etanercept.
Right. Right. Okay. Thank you so much for this. Uh, I think just in the interest of time, I'm going to move ahead. And this one is, this question is for Miss Lakshmi. Uh, you know, like really, like all the people going through bone marrow transplant are anyway, there's a high level of anxiety, like just the way the settings are, right? You're in a separate unit, in a BMT unit, you're kind of, cut off from the rest of them. And there is one caregiver with you all the time. So how does one approach this new event, called GvHD in their lives? And what kind of changes, because it makes changes to the body and mind also, right? Because GvHD can be acute and it can trigger so much more, like the chemo fog or the chemo brain and stuff. So how does one approach this problem, or what is your conversations with the caregivers during this stage? And how do we manage fear and anxiety resulting from GvHD? I'm just going to club these questions in the interest of time.
Yes. Thank you for the question, sir. One of the first and most important thing in this setting becomes information. Having the adequate as well as the accurate amount of information becomes very crucial, because a lot of settings, it is the lack of information or misinformation regarding the progression of GvHD, or what are the signs, what are symptoms, what can I do, what is not in my control. This information is what becomes first and primary intervention here by adequate information.
Lakshmi,
And to
sorry to bother you.
understand that.
Hello, Lakshmi. Can you turn on
Yeah.
your video, please? I don't think we can see you. We can hear you, but we can't see you.
My video is switched.
It's switch on? Okay. Can't hear you, see you. Probably that's the reason. Okay. Yeah. Because we are live on YouTube as well. Okay. Okay. Yes, thank you.
Am I visible now?
Yes, yes, much. Yeah.
Yeah, I think I had a technical error, sorry. Yeah, so as I was saying, information becomes important, and ensuring that progression is different for every patient and it's not something that you can compare. That information becomes very crucial to both the patient as well as the caregivers. And also focusing on what is in our control and what is not in our control. And what is in our control in this point becomes your self-care, your diet, your nutrition, your relaxation techniques, and ensuring that priority is given to these regular daily aspects of our lives becomes very important. We might think that they're very regular aspects, such as going on a walk every day or eating healthy food or relaxation techniques. These might seem very simple, but the fact that prioritizing this does help with our body, as you rightly mentioned, the mind-body connection is something that becomes very crucial at this stage. Moving on to the fear and anxiety part. Again, understanding what is it that is causing anxiety or fear in me. And for example, if it is not knowing what is going to happen, how can I get the information for that? So kind of isolating what is creating fear in me rather than having a general idea that, oh, I'm afraid, there is anxiety about this. Understanding what exactly is causing the fear and addressing that becomes important. And sort of reframing your fears into practical concerns, like I mentioned, and reframing them into practical aspects so that we can provide resources or coping mechanisms in order to address them. Again, relaxation techniques such as breathing exercises or grounding techniques becomes very, very important in order to sort of ground yourself in the moment. And it also equips with resilience in that moment when there is a sense of fear. Grounding techniques is something that we use a lot in order to sort of bring our focus back to the present and see what it is that we can do in this moment rather than worrying about the 10 possibilities that could happen. So more on the lines of information and awareness is what we work on in terms of GvHD for our patients.
So excellent, lucky. And I think just we are, I just want to do a time check here because I think we are almost nearing the end of the session now. So Dr. Venkatesh, should we go ahead with the rest of the questions or should we take up questions from the audience? What's your suggestion?
Yes, I think one more slide which may
Okay.
answer. Yeah, I think the last slide should be important. Yeah.
Fantastic. Okay. So this one's for you, Dr. Ranjit here. Is like, like 2 to 3 weeks on steroids and cyclosporin. What are the risks of infections during this 2 to 3 week period while the GvHD is being managed so that nothing new crops up? I think is always a question for most of us. So what would be your advice here?
Yes, that was a very interesting question. And because during GvHD, when the patients are on steroids, now GvHD and infections, they are hand in hand, you know. And I'm telling you, this is from my experience. Uh, if the type of GvHD is nice, you give steroids, the GvHD will be controlled, there would not be any infections, period. So that is the best type of situation we have. Now that happens in close to 20 to 30%. In another 70 to 80%, both these things will be troublesome. So the GvHD will be partially controlled or maybe a little better controlled, but then there are instances of infection. So the infection which is most important here are the viral infections like cytomegalovirus. So while on steroids, when the patient is for GvHD, you should be monitoring cytomegalovirus at least once in a week. And once the titers it increases, you start the treatment very, very rapidly. And the other infections which are also important during such situations are the bacterial infections. These are your conventional gram negative, gram positive infections happen at a little more commonly here. And then the other things like fungal infections. So when the patient is on steroids, you have to be absolutely controlling the blood sugars pretty nicely. These patients are to be put on antifungal drugs which covers for something like aspergillus, the anti-invasive infections. So you have to do a lot of prophylaxis during this time, a lot of surveillance as well, that these patients they do not run into a lot of infections. But having told that, if it is a good situation, you give steroids, GvHD gets controlled, infection doesn't happen. So it is not always that you give steroids and infection would always happen. It's not like that. Thank you.
Absolutely. And just the last word from you and Dr. Ritu both, can acute GvHD be cured? I think, we just want to, because most of the patients just want to know this saying, can it be cured? Or is it to be managed long term? I think that's always, the question from most patients. So yeah, over to you, Dr. Ranjit, first for that.
So if we are calling it as an acute thing, all the things that are acute, they are potentially curable. Acute means that it gives you a good window to cure it off. So acute GvHD is curable in most. But in close to two-thirds of these patients, acute GvHD is followed by chronic GvHD. We tend to, differentiate these two things, but these are things in continuum. While acute GvHD you are treating, the chronic GvHD process has started happening. So if you are only calling acute GvHD whether that can be cured, yes, it can be completely cured. But then one thing leads to the other. In two-thirds of the patients, the chronic GvHD is just about happening in a few weeks or maybe a few months.
Okay, fantastic. And now, Dr. Ritu, just one word from you on the same topic with your experience.
Yeah, I agree with Ranjit that it's not a compartment that it's acute GvHD and then you will have chronic. So its overlap is also there. But yes, in a majority of the patients, if the diagnosis is done promptly, because acute GvHD is an inflammatory response. So in steroid, if you start before the damage has been done, most of the patients will be cured. So I always tell most of our residents also that GvHD managing is an art. It's detect. We don't have tests to detect. It goes by the clinical experience. You have to preempt that, okay, this, like, keep a high level of suspicion, keep a low level of threshold for starting your steroids. It is difficult at times, especially in acute GvHD. Sometimes there are infection, there are low counts also. So sometimes it becomes tricky to start steroids. But yes, in the majority of the patient, it started early and in the proper correct doses it can be cured. And I tell patients that don't get scared of GvHD. We actually, I do malignant transplant because I'm an oncologist. So we cure you and we give you another disease called GvHD. So GvHD treatment diagnosis is an art, and yes, there are long-term implications of the GvHD and the treatment also.
Okay.
That is excellent. Thank you so much, Dr. Ritu.
Yes.
Yeah, Dr. Venkatesh, you want to?
Yes, I think thank you very much, all the panelists, for throwing light and throwing their and using their entire experience in answering these questions in a very straightforward, clear way, so that patients who are worried about their risk and the part where acute GvHD has always been a problem, they are reassured that we can totally get over it and treat, and your quality of life can be near normal. I'm glad that we had this discussion. And subsequently, we will also be talking about the chronic GvHD, and we will also address questions around the quality of life and how we can improve quality of life around this problem in a more detailed manner. Thank you, everyone. We move on to a vote of thanks. And I invite Neeraj Trivedi to give us a vote of thanks. We are at the end of today's session. Neerav, can you change the slides, please? If you
Sir, we have Sheetal Vaidya ma'am to give the
Okay,
vote
so
of
we
thanks.
have Sheetal Vaidya, ma'am. Sorry, I did not know that. Right, Miss Sheetal Vaidya joins us for a vote of thanks. She is a co-founder, BMT Support Foundation, Pune, works closely in association with patients, along with Neeraj Trivedi. Over to you, Sheetal ma'am.
Thank you so much, sir. To begin with, I really thank Dr. Ranjit Sahu for throwing light on such an important topic, GvHD, which is a critical part of transplant and an unknown space for most of the patients and caregivers. Thanks to all panelists, including Dr. Ranjit again, Ms. Lakshmi Verma, Dr. Ritu Jain, and Dr. Rachna, for answering important questions. And I'm sure that, more will follow. This is not just enough. I think there are so many more questions that will come, and we hope that we can follow it up. This call can be followed up by answering those. And thanks, Neeraj, for moderating that panel. It felt like we could have gone another half an hour into the questions and knowing more. So thank you so much. And especially thank you, Dr. Venkatesh and Revati Raj, Dr. Revati Raj, and ISBMT team who has supported to success of this call, because this is such a critical topic, and most of the times, like I said, it's an unknown space. So, we have really Thank you for taking this initiative, for bringing this call, and many thanks to all the participants who took out time on this Saturday to be a part of the call. So thank you all for being a very active audience. Thank you, sir. Thank you, Dr. Venkatesh.
Thank you so much, Sheetal ma'am. It is always good to hear from patients when it comes to feedback. Very rarely do we get that opportunity. We also have an upcoming webinar session on 8th of February, as usual, the second Saturday of each month, as an ISBMT patient support group. The webinar series will be we'll be talking about nutrition in bone marrow transplantation, which essentially is at the as the backbone of all interventions which are patient related, and it will be a wonderful discussion. I would like to invite all of you to join us on 8th of February 2025, 3 to 4 p.m. for our webinar series number 6 on nutrition in BMT. Once again, thank you all from Indian Society of Blood and Marrow Transplantation for joining us on webinar number 5. Thank you.
Thank you.
Yeah, thank you.
Thank you, everyone. Thank you.
Thank you all.
Thank you.
Thank you so much. Yes, thank you so much, Dr. Venkatesh. I think this is wonderful.
Thank you. Thank you, Veera, for everything.
Thanks.
It was good. Thanks.